everyone, and welcome to our webinar. My name is Lauren May with Iatrix Systems, and I will be your moderator today. We have a few housekeeping items to get through before we get started. First, if you need any technical assistance throughout the webinar, you can either hop over to the question sections in your control panel or send me an email and I will help you out. If you have any general questions during the webinar about the content, again, feel free to go to the questions pane, type in your question, and we will get to it during a pause for questions. Just so that you know, we are recording this webinar for quality purposes. And at the end of the webinar, there's a survey that you can take. By taking the survey, you will have a chance to win a $100 Amazon gift card. You will automatically be entered into our entered into our drawing by taking the survey at a drawing that will be held at the end of every month. And now I would like to officially welcome you to our webinar, Know Your Patient Data Before You Send It Elsewhere. Today, our speaker is Rob English. Rob is the Practice Director for Iatrix Systems Professional Services. His background includes extensive experience with project management, implementation, programming, integration with EMPIs, interface engines, and HIEs. Rob has more than 20 years of healthcare experience. And now I will turn it over to Rob.
Great. Thank you, Lauren. And thank you guys for joining today. Again, know your patient data before you send it elsewhere. Kind of an all-encompassing, what is your patient data? What does that include? What kind of information is that? And when you send it elsewhere, where would you want to send it? So we'll kind of start off with an agenda here. Why accurate patient data is important. We'll go over those items. Knowing and controlling your data. Get a little bit into EMPI best practices just so you have an idea. I did notice some HIM folks on the call. Realizing value from your connected community, and then case studies, what we've actually seen when we've done some data cleanups or when we've helped people connect to a community prior to them connecting, or when we've worked with a large HIE and actually seen the data that's come in. So we've actually seen it from both sides and can share a little bit of that information. Again, as Lauren stated, we're going to have this recorded, but we'll also send out this PDF or a PDF of this presentation so you don't have to take a ton of notes if you don't want to. It'll all be in that PDF. Again, why accurate patient data is important. Obviously, the impact of sharing bad data is not good. You want to have credibility and maintain credibility with your patients, providers, and clinicians. Obviously, for patient safety, if we choose the wrong one and make updates, that could cause harm, not only to the patient, but it could be 2 or 3 different people that could be included with that. And overall cost, transferring a larger than needed number of entities into your new EHR if you are upgrading or moving to a different EHR. You may not want to move a lot of bad data or duplicate data across your system. So identifying duplicates within your system, a duplicate really represents 2 or more records that are the same person within a source system or across multiple source systems. And so why is that important? A duplicate or overlap when it crosses multiple systems that you may not have control of creates segmented data in the same source or across source systems. So obviously segmented data could be clinical data other than patient demographics. So we want to make sure that we try and identify especially duplicates within your same EHR so that you can get those remediated and rolled up into the same person so that if you do share that information outside, it won't be segregated. So you won't have one patient record with allergies and another patient that represents the same person without allergies. And so you want to merge those on the same source side. And then if it's across multiple sources, you can either do that within your system if you have the ability with an outside EMPI, or you can have the HIE link those records together. So that's kind of where you can help with a connected community is, hey, these 2 people should be the same person, so let's go ahead and link those records together. And just a few stats on patient identity. The ONC wants a 2% duplicate rate, or recommends a 2% duplicate rate. A lot of folks, as we'll see in another slide, may not even know what their duplicate rate is within their EHR. We've seen duplicate rates as high as 30+%. So that's quite a few. You know, one in 3 or 4 patients are the same, and they didn't know it really. And so that was a good eye opener for them, so that they could then go and clean those up. Another thing that we've seen over time is, and this is a statistics from ID Analytics, is that 40 million Social Security numbers are associated with multiple people. So that's roughly 20 million Americans have multiple Social Security numbers. And so that could be a fraud, that could be just a mistake, a key entry error, those types of things. But just some stats on that. And then when we get to additional stats, you know, how many folks know what their duplicate rate is within their EHR? A lot of folks don't even know that. So 45%, as you can see from this study from AHIMA, don't even know what their duplicate rate is. 19% know that it's between 1 and 3%, and then 18% less than 1% duplicate rate. And then the rest make up higher rates than that. So overall, you know, once you get into these 1 to 3 or 1% ranges, that's great. But anything higher means that your EHR, or if you want to share that data, is going to have segregated information across it. Fixing duplicate rate improves outcomes, obviously. So regulatory provides better results for your public health or incentive payment programs. You know, there's obviously numerators and denominators in there. So getting unique patients down so that it's a truly valid number. Financial ensures the accurate billing, ensures correct insurance, reduce costs of unnecessary tests, those types of things. Patient outcome ensures that accurate diagnosis and treatment for the patient, or treatment protocols. Also, when patients see accurate info in their portals, a lot of folks have patient portals, that just instills a lot of confidence that their records are intact and they have all the information they have that they know about when it comes to their visits and things like that. And process, by knowing your duplicate rate, you can identify process improvements and fix that in the problem areas. And also, you know, we've seen a lot of good systems that had very low duplicate rates, and just telling your staff, hey, you guys are doing a great job, you know, that instills confidence in them and helps them to continue doing that really good job. Challenges associated with patient matching. Obviously, disparate and incomplete clinical information on patients across the enterprise, that's a challenge that we're trying to overcome. Billing duplications, manage patient populations within a facility or across an enterprise, obviously mislabels, father-son due to junior-senior confusion. Confusion between individuals with similar information from the same address. We've seen a lot of folks from assisted living that may get linked up, especially if their names are very similar. Could be one instance where there's a John. Obviously, there could be multiple John Smiths at the same address, so it may link those up together. And then incorrectly not matching records within a facility. Obviously, deterministic matching, where you're just matching on an exact first and exact last name. If anyone goes by a nickname, that can present a risk. Bidirectional interfaces. I've seen that where if they're not using a distinct ID for matching, you get in the first name, last name, and maybe date of birth. And if they didn't spell it right the second visit or the third visit, then it could create another encounter or visit within your EMR itself. And then incorrectly matching records within your facility. You want something that's going to help you identify overlays in that particular instance. So if you can find the same MRN and it has and someone has entered information that is very different than what it was previously, and it could have been just a mistake when someone might have brought up, such as my name, and my wife is going in for a visit, and they were looking up an address, and then they turn around and type her information over my information. That would drastically change the information on that specific medical record number. So we want to make sure that you're aware of that, because we wouldn't want my test associated with my wife's new test. So overlays are a good example of why you would want to make sure you have some process around identifying those. EMPI, what to do when you don't have an EMPI, what to do if your EMPI doesn't tell you what your data, that your data is clean. You need to understand your data, who's doing what, best practices in monitoring what your data entry is. Not all EMPIs are created equal. Obviously, some are deterministic only, some are deterministic and probabilistic, some are just probabilistic. I think an equal match of probabilistic and deterministic is very helpful because you get that probabilistic component, so the weighting of different demographic information. Also with rules that you could create after the fact if they meet a certain threshold from a probabilistic standpoint. So there's also other more robust algorithms that could be available as time goes on. Obviously, there's different things that come out and programming change for languages and those types of things that can help in matching patient records. There's multiple vendors out there, best of class EMPI vendor, and there's cloud hosted versus on-premise. So you could actually have your EMPI in the cloud, send information and get information back. And then hopefully that would help you out when you're either entering folks into your EMR or when you're trying to remediate duplicates within your EMR. If you do clean up, if you're migrating or wanting to clean up your data before you start sending that off to a connected community in HIE, you want to make sure that you have, your duplicate rate. You know that you need to start a cleanup, pretty far out before that. It may not be a 1 week process. You may need to start that 3 to 4 months out before you actually do something with that data, and then plan for moving clean data into either a new EMR or an upgraded EMR or into a HIE itself. Knowing and controlling your data. Why controlling patient data is important to success. How and where do I send my data? I want to make sure my data is accurate because that represents my organization, especially if you're going to send it to a connected community. So there's many participants outside of just your organization that may see that data. So you may want to know who's in the community and who you're contributing to and who your partners are. But also that your data is also helping provide care to patients that once they aggregate all that information, they have a better picture of what their clinical information is, especially within a geographic region or referral network, such as a connected community. Why controlling patient data is important. Again, how will it be utilized? Referral networks, routing of lab, radiology and transcriptions, patient summaries, documents, radiology images, those types of things. It really starts with the patient, and then things get added to that if you think about it. So the patient is itself an HIE. So, and it could go, the patient or the person can go to multiple facilities and get all types of things done. But they want that in one, it would be great to have that in one location so that that information can be viewed by others. And then what do you want to expect to get back? How do others get you data, right, from your connected community? Are you going to receive just HL7 messages? Do you want to receive documents? You want to look at images, those types of things. So, sending accurate data and wanting to receive accurate data is a great way for connected communities to work together. What's required to have data control? So obviously, if you want to work with a different community or outside of your organization, data sharing agreements, PHI, legal steps, do's and don'ts. Does your community partner keep the data in-house? Those are just some of the questions you may want to ask if you're going to send your data outside. Do they have a unique identifier to your source system, or do you have a unique identifier to your source system? So a single enterprise patient identifier reduces the number of interfaces. So if you're sending your data out, you want to make sure that every time you do send that data out, it matches up to the same person that you created the first time, unless there is a link or you need to do a merge or things like that. Inpatient and outpatients, are there differences, and how should that information be sent out? Corporate EMPIs, in the event that there's lots of systems within your organization, how will that be incorporated into connected community? You know, if you had an EMPI across multiple sources or multiple EMRs within your organization, are they going to utilize your EMPI number? How is that EMPI number going to be updated when it gets sent out? Or how is that EMPI number going to get linked with others if you link it within your organization? So just some things you want to think about when you do send out data. And then, sorry, I'm having a difficult time with my mouse there. Realizing results. Obviously reduce the redundant procedures as you send your data out and get information back. Cuts down on duplicate testing and procedures for patients, and also provides a better history for any provider that would want to see that information. Point-to-point interfaces. By connecting to a community, you can cut down or reduce the number of interfaces you manage and rely heavily on the connected community to send that information elsewhere. So you receive a lot of benefit without doing a lot of heavy lifting or interfacing if you go with a connected community. Results routing is another way. Get results automatically if your community can provide that. So if one of your providers is attending or admitting or just a consulting physician, they may want to see what results get sent back on specific patients. So you can sign up with that with your connected community. Those get routed back to you automatically. Realizing results, EHR integration with interoperability, standard-based protocols. You know, standards, yes. Are they always standard? Probably not, but they're just a little bit off. So just having someone who can interpret that for you within your organization or within a connected community. Do you have the ability to receive this data in a document format? So can you consume CCDAs? Do you parse those discretely, or is it just a viewable document? Just some of the things you want to think about when you do send data and when you do receive data back. Obviously, EMPI consolidation at the community. The community EMPI should identify and manage those entities. They're going to work with a lot of entities just outside of what you're providing. So that's going to benefit you, because that hopefully you sending a patient demographic out will link with that patient as he's gone or she has gone across the continuum of care there, and you can get all that information back to have a consolidated record. So in realizing the results of sending your data out, and some of those things are, you know your connected community and its goals. So who are the participants? How are they going to maintain themselves, sustainability and cost? And the vendor platform, what are they working on? Is it from X vendor? Is it multiple vendors? Those types of things that may influence your decision on sending data and understanding how that's going to work for you. What will you do as a participant, and what will you need to provide? You know, connectivity, obviously you're going to have to connect to someone outside of your organization, how that's going to work with VPNs or secure tunnels, those types of things, what data types you're going to need to send, and what's your staff's involvement from an interface perspective, from working duplicates, from testing, all those types of things. And then how will your data be housed and protected? Obviously, PHI want to make sure that data is protected and only certain people have access to it. Also, from a break the class perspective, that it's audited. If someone does look at that data that may not have a relationship with the patient. Consent, opt-in, opt-out, that's obviously something else you want to consider when you're going outside of your organization to provide data, and how consent is managed, and how will you get access to the consolidated aggregated record? Are they going to send you back a document? Can I do that discreetly, or is it just viewable in my EHR? Is it a portal that a provider has to log onto and look at that information, or can they provide other means of getting that data back, such as HL7 messaging or something like that? Best practices. So before you do, a good recommendation is before you do send your data out, analyze your data. If you don't have an EMPI, there's lots of vendors that could probably help you out with that and analyze your data so that you do know your duplicate rate within your system, within your organization, whether that's multiple EHRs or just a single EHR, and then understand where the problems areas are. It could be that it's specific to one department. It could be specific to certain registration areas, those types of things. And then understand where the data came from. Obviously, again, facilities, different locations, and then kind of what we've learned from analyzing millions of records, develop consistent business rules for patient demographics. If they go by a nickname, but their driver's license says John instead of Johnny, then, you know, we're going to add John. They can have an alias name of Johnny if they want, but it's John on your driver's license. Again, start planning early for any data migration. It's usually not a week's thing, it's more like a month's thing. And then budget for any remediation efforts that you may have. It may not be fun. It's not the sexiest thing in the world to go and link up a bunch of records day in and day out, but it's something that obviously needs to get done. What can you do next week to improve your data? In your EMPI, registers, do they know their value? Obviously, that's the one that's talking to the patient, looking at the information and trying to gain that information from a demographic perspective. Make sure that they have a process that they go through with everyone and get that information, whether it's go strictly by the driver's license information, or take nicknames, those types of things. Share use cases with them where it worked out really well and they have a low duplicate rate, or it's kind of bad and we want to get this fixed. So how can we fix that? Educate them. Again, case studies, analytics, safety outcomes, how much time it will save in the end if it's done correctly on the front end, and then celebrate success. Tell them they're doing a great job, because those are the folks that are in front of your patients or folks, and you want them to make sure they get the right information. Policy and procedure, make sure expectations are documented. Again, name must match on the license or ID card. Educate and re-educate, hold people accountable, and have processes in place to handle mistakes. Mistakes can be made. You know, it just may be an entry error on a social security number. So how are we going to fix that? And how, once we do fix that, how is that handled downstream? I fixed my mistake. What's next? Before moving on, consider the ripple effects. If you do a lot of remediation, you want to consider what happens to downstream systems. That's one thing. Alias identity, if you know, it's good when it's a maiden name. Joan Smith changed to Joan Jones, which would be crazy, but we've seen things like that. But it's bad when there's an incorrect alias on there, because that's part of the history of the record in most EMPIs. So in a lot of cases, that's used as from a matching perspective. So could provide a bad match again, just because it has an incorrect alias. Increased matching score if it's an incorrect identity, again, if it's a bad alias, or if you do have incorrect matches. If folks are getting matched incorrectly, you want to make sure that you understand why it's getting matched and remove elements if you need to. So logically deleting elements, so it's taken out of any comparison on a probabilistic algorithm. And then again, downstream systems, consider that, you know, maybe there's a PAC system that uses a specific number, and even though you've updated the patient information, that number may or may not still be in that transaction. So you want to make sure it matches somehow. Educate your team on the process for correction. Again, remove the aliases and make sure that both accounts, if they're not updated asynchronously, how those accounts get corrected. And you may have to update both of those accounts. Educate your patients, you know, tell them why you want the correct information so that you can provide the best care for them, so that you can match their records as they've gone through a continuum of care outside of your organization. Outreach, set the goals, follow up and re-educate, right? Set goals on how you're going to update your patients or inform them of what you're trying to do with that information, follow up with them and re-educate. You know, goals for patients should carry an ID. Usually a driver's license, everyone usually has a driver's license, and it should have the correct information on it. Biometric registry, maybe a little far off on that, but maybe not. Maybe it's a thumb. You know, a lot of folks want to go to an iris scan or something like that, which may be a little more invasive for some folks, but if biometric is available, then go for that. Share information with your family or make them someone that can access your records, and check your patient portal. Make sure it's accurate. You know, you want them to help you keep an accurate information for them. And then realizing your data from, realizing the value from your connected community. So what are you going to get back? What's in it for me, right? Because you're going to feel like you're doing a lot of heavy lifting, interfacing, you're doing a lot of things to get connected in there. It's all in there. Once you get it all connected, now what do we do? And how do we compare to other members? Let them give you reports or something that says, hey, you guys are providing great data, or your comparisons are matching across the connected community. And then are other members looking at your data? Are they utilizing it, right? So if Medicaid or Medicare starts adding information into the system, do you get the benefit of that? And do they get the benefit of looking at your data? What if they're not as careful or as thoughtful on their data as you are? What can we do to correct that? Are there golden records, and can we excuse some of those out of the golden record so that we don't have to accept that information if we do want it back? And then how will I get data out? Can I get reports? Can I get documents? Can I get transactions sent to me? More is better. The more who join a connected community, the more powerful it becomes. The early adopters, the pioneers, take the greatest risk, but it's for the greater good. Understand your network shared visions for patients, for providers, hospital, the network, the community. How does your connected community, or do your connected community homework? Again, look into that connected community governance. Who has access? Patient identity. Do they have an EMPI? Onboarding. How do they get new records onto your system, and how are those remediated once they come on? Patients. What do patients get out of that connected community itself? Meaningful use. Do they help you? Does it provide for you and give you information for meaningful use or public health reporting? And what types of analytics are available for that? Another one would be in what type of auditing or logging is available if someone breaks the glass, and those types of things. Patient identity is the priority from a health exchange or connected community, right? So we're sending in a lot of information. again, it starts with the person or the patient. They're the HIE themselves for all of their information across the community. So make sure your community has established protocols around patient identity and is committed to a low duplicate rate. We saw the 2% for ONC. They want to actually come down to 0.05% or 0.5% and then 0.1% in the coming years. So in the near future, they want to be down to a very, very low duplicate rate. So you want to make sure that wherever you're sharing your data, they're able to get to that rate, or at least they're working towards that rate. So you have a warm fuzzy around it. How can we make the connected community work for us? Obviously, you're providing data. You may be providing funds for that, but be an active member. Voice what you would like to see. Make sure that you've vetted the connected community pretty well. If you have that opportunity, expect analytics from your data. Expect analytics from the entire system. Publish those and follow up with sluggish providers and patients, right? If they're not providing all the information, then let's make sure that we can get them to follow up with the protocols and those types of things. Gather and share success stories on what you've learned and re-educate as necessary. Providers, registrars, HIM folks, whatever it takes in order to get your connected community working for you. Obviously, patient identity in a connected community works a little different because they see entities from they see records from multiple sources, whereas you may be providing only a single record from a single source. So just some things that you may want to look into is what is EMPI is a connected community using? What's their duplicate rate? What process do they use when they onboard new systems? Do they analyze it? How do they remediate it? Do they have enough staff to remediate it, or do they just let it auto-link? Just some things like that. Duplicate rate goals. What are they looking for? Best practices from registration, licensing, or biometric accountability. And what are their merge or unmerge practices from a connected community perspective? Some case studies, what we've actually seen out there in the field. This one is a case study of a very large EHR system. Had 445 beds. Go to the next slide here. They were moving 3 systems into one system, and they wanted to move as one record representing multiple MRNs. So they had 3 EHRs that they wanted to move to a single EHR, and they wanted that to have a single record number so that they could send that over and just have that single record number as its unique identifier in the new system. Obviously, had data poor records in some of those, so we wanted to look through some of those and see what we could do to either not include those or fix those prior to extracting that data. Missing data, bad records, incorrect data, those types of things. And thousands of the records had generic data for real patients, the 190101 birth date, or the all one social security number, or the 111 anywhere place address, those types of things that you may want to fix or remove before you do anything with that data. Saw lots of those. Planning, assessment to understand the duplicate rate, moving from these 3 different sources to a single. This particular case, they had 35.4% duplicate rate. And obviously we were able to show them that was a problem. We made a plan to get right data into their new EHR or new EMR. Some of the times we said, hey, let's not move data over 5 years old or something like that, because this system had been around for quite some time. Remediation, clerical review, and cleanup. The site had dedicated HIM personnel, which were ready to go. They were in charge for managing the data cleanup. They were empowered to make decisions around which patient identity should last or should move forward. And that definitely kept the project moving in a forward direction and quickly. And quickly, again, was months, but it was quickly. Integration perspective, we prepared a demographic load for their new EMR. So once we had the entity, we were able to meet the specifications for the new location that it was going to, and so we were able to create that demographic load. The new EMR didn't have a predefined format to accept data, so they didn't accept all the items, so we had to configure the EMR side to get that information into it. So in certain EMRs, you can have custom fields or those types of things, but we wanted all that information into that new EMR system, so they were able to create these custom fields, and we were able to do that. Definition of process and procedures for generic values. If there's all ones in Social Security number, don't let that compare. If there's you know, a 1901, let's don't use that from a comparison perspective, those types of things. So the key takeaways, having the HIM person in charge and empowered to make decisions on data kept the project moving. So that was one thing that really helped us move forward in this project. Knowing your data, have a way to determine your duplicate rate and identify the problem. We analyzed the data for them. They knew what their duplicate rate was when they saw it all together. They didn't ever have that opportunity with the 3 disparate EMRs. So once we put all their data together and did analysis from an entity perspective, they were able to see that and understand what their duplicate rate was. And they knew that it was going to take resources, so they had allocated those resources to fix it. And then the other key thing was don't orphan your downstream systems. We did find out that you know, we needed to do something with downstream systems to identify them, that these records were moving from multiple medical record numbers to a single entity ID. So whatever we needed to do that, we were able to do either through a file exchange or in some cases it was manual. But just remember to not orphan your downstream systems. And then for another case study, so the previous case study was with a single entity. They're wanting to upgrade. They did want to share their data with their HIE at some point, but they wanted to clean house before they actually started sending that out. The second case study is we actually worked with an HIE, so this is the other side, and what we see from that perspective. It is a state community. There were 24 participating facilities, 15 million records. It's currently gone up to about 18 million now. They had 10 million entities, which has gone up to around 11 and a half. They've now been operating for about 4+ years. And an onboarding process for assessing new participants' data. Something that we did when we first started this was we just loaded all the data from the early adopters, I guess you can say. So we loaded all that data, which, as you can imagine, created a lot of duplicates where we had to have remediation and staff to do that. So we did ramp up for that for a short period of time and get those duplicates linked together so that they were one entity. EMPI, it was a hot mess. The EMPI system itself, again, had a lot of remediation to go through, and we needed to refine that remediation process. So we put some rules around it. If you see X, Y, and Z and A together, then we're going to make that a link, those types of things. The new system had no reporting capability when it came to duplicates or how people are managing the remediation process or those types of things. So we helped them with reporting just to see how many duplicates or linkages they were doing in a day and how much more staff we may need in order to catch up in a certain period of time. And again, we manage the overall task management or the remediation process. So we managed at one point, 18 folks to come in and link those records together on a full-time basis for about 12 weeks and got that task list down to a manageable level on a daily basis. Reports, again, we created the reports to find the biggest issues, how names were spelled, were their addresses at the same location, those types of things. Source counts from these reports, entity counts, user resolution and productivity by person, and then lots of other things that we wanted to look at. How many Smiths do we have in the system? How many male and female? Those types of things were great things that the connected community wanted to see from its data that they were receiving from all their participants. They also wanted to see how many folks are sending us all ones for social security numbers, how many folks are sending us all 1900 for birth dates, those types of things. So we could create better rules and matching around that. Again, the bad data elements, new sites with data poor records. And data poor is they may only have first name, last name, and date of birth. That's not going to really match well with some of your other records. So you have to decide what you're going to do with those records. Are we just going to let them be single folks, which we normally did, and hope that in the future that specific facility would add more elements as the record grew itself. Went through and did different algorithm tunings, and again, manage the resources for cleanup. The key takeaways, they need to have a clean data if sending data to the community. So, I'm sorry, the need to have clean data. So what we talked about previously is cleaning up your house before you send it to some other one's house, and having that data clean before it gets sent out. If you're a joining community, make sure they have some established EMPI practices. Ask the questions, how do they remediate? What demographic elements do they look at? What's the score? What's the auto link threshold? What's the task threshold? If they don't have a task threshold, how do you find those records? Those types of things. And again, other questions to ask is just how do they remediate when onboarding new sources, and what are their documented practices around how data should be handled? You know, if you have 10 million records in your system and you get another facility that only has maybe 30,000 records, that's not going to be a huge impact. But if you have 10 million records and you get a source that's going to add another 5 million records, that's a huge impact on your data and on your matching. So you want to make sure they've done their homework around that in the connected community and their entity, so that they can either ramp up for the linkages that may occur, or they can tune their algorithms to better suit that new source that comes on. So data cleanup process, know your data, know your processes, have those aligned, assign the resources, update your algorithms if you have an EMPI that's probabilistic in nature. If you don't, and it's just deterministic, or you have rules, you may want to look at those again. Referential matching. Referential matching is where you can send information to an outside source that may have data from other sources, such as court records or driver's license locations, or those types of things, so that that data may be more accurate. And if your record matches up, they can give you a key, so that if you see that key on another record across the source, it can match together. So there are some referential matching companies out there. And then just overall, keep your data clean. Brings us to Q&A. So Lauren, I guess I'll send that back to you and see if there's any questions out there.
Thank you. Currently, we don't have any questions. I'd like to just remind the audience that you can type in questions into the control panel, and now is the time that we would like to read them aloud. So we'll give everyone maybe a couple more seconds to see if there's any last-minute questions. Okay, I think that we don't have any questions today. I think you did such a great job that there aren't any questions left.
I'm sure some may come, but again, you'll receive the document, and I believe it's recorded also. And then if you have questions after that, don't feel free to reach out, and we can hopefully help you out.
Thank you so much, Rob.